Hey everyone, welcome to Getting Back to Zero. Thursday evening, great to have everyone here. Hope everyone had a great holiday weekend. I know I did. Very excited about tonight. I have back a return guest, and we are going to now pick her brain even more. But we have with us tonight Dr. Melissa Fritsche, who is an addiction specialist. She's a board-certified addiction medicine physician, and she recently became, and I have no clue what this means, a fellow for American Society of Addictive Medicine. So I am thrilled to have our specialist on the medicinal side of this to join us. Dr. Fritsche, welcome to Getting Back to Zero. How you doing?
I am great. How are you, Jeff?
What the heck is a fellow for American Society of Addiction Medicine?
Fellows. A fellow is just frequently in the medical field a way of recognizing someone who is sort of engaged in participating in some of the professional education and societies and just sort of keeping up with things. So I was honored to receive that.
So basically, your wall behind you gets more of those things hanging on it because of the fellow, and your name will have more letters behind it.
That's exactly what it means.
That's what it means.
Certificates and letters.
That's fantastic. Well, I am so glad to have you here. Obviously, I come from an AA side of things. This group is not about any program. We are just recovery or sobriety support. But there's a lot of questions about the medicinal side. So that's kind of, you were on once before and everyone loved you because you made things simple, which is perfect for me. And you usually didn't laugh too hard at the stupid questions I had. So we're going to start, but we could save us all a lot of time. This whole recovery crap, have you found one of these that will turn me from an alcoholic to a non-alcoholic and let me go back to drinking normally?
Well, so it's not one of those, but what I do have here in my office.
Oh, the magic wand?
I do.
Perfect.
See, and I have this right here in my office to explain to people what I can do for them.
Well, let's hear it, because
and what I can't do for them.
Right.
And what I can't do for you, Jeff,
is wave the magic and and turn me into what I wish I was.
Right.
But I can come close by working things. I understand it. It's always, my whole life has been the magic pill for everything.
Yeah. Right.
And including exercise, including becoming good at an instrument or any other skill. I want the pill so I can just be there without having to do the work. And this is one that I'm learning now. I'm loving doing the work, and the rewards are fantastic. But let's get to the medicinal side of things, because you hear a lot of people. I want to start with the detox, but I know there's a lot of medicinal people ask, what can I take for cravings? What can I do to make things easier so I desire to drink less? But before we get into that, detox is a word we hear a lot, and it scares the hell out of a lot of people. I've heard if we don't get professional treatment, we die. If we don't with detox. Now, I did go into a facility, and I don't even know if I went through any DTs or withdrawals or what that. So explain that. But I hear a lot of people say, you know what? I have kids. I can't leave my family for 7 days or 25 days or whatever the stint is. I can't do it to go through recovery. I'm scared to death that I'm going to die tonight if I stop drinking. So what are the answers to that?
Right. So the thing I love about doing interviews with you is that you ask 47 questions in one.
And then I get to sit back and just watch the show and enjoy. And take notes.
So let's talk about the magic wand and medicine. And, in treating folks with alcohol use disorder, so my practice, I have a full addiction medicine practice. So I treat patients not based on which substance they use, but for addiction. And most of my patients are either alcohol use disorder or opiate use disorder. So for alcohol use disorder, from the medical perspective, we're talking usually about two different phases of treatment. So the one question is, what can I do to support my sobriety? All right. So that is, I have decided to stop drinking. I have successfully stopped drinking, or in some cases to try to control my drinking, so drinking less. And are there medication options available to help support me either in my complete sobriety or in my controlled drinking? And the answer to that question is yes. But I think the question that you were sort of pushing toward was the other piece medically that we can help with, which is in most people's minds something called detox. It's what medical professionals refer to as medically supervised withdrawal. So what medically supervised withdrawal is for is to help people stop drinking who are drinking heavily and may be actually physically dependent on the alcohol, and may therefore, because they are physically dependent on the alcohol, experience a certain amount of withdrawal when they try to stop drinking.
How do they know how do I know if I'm physically addicted to it, or if I just have bad habits? How do I know if I have that physical addiction, and am I going to go through that?
Right. So just because from a professional perspective, we like to keep those words clarified, there's a difference between dependence and addiction. Okay. So addiction is the piece that involves some of the behaviors and the difficulty that people have not using a substance. But physical dependence is very different. And you can be physically dependent on something without being addicted to it. Okay. So physical dependence on a substance means if you stop using the substance, you experience withdrawal symptoms from that substance that usually mean you will start using the substance again. Now, you may know there are medications that are prescribed by physicians that people can develop a dependence to, which doesn't mean necessarily that they are addicted to the medicine, but it does mean they are physically dependent. And so they have to be carefully supervised tapering off of that medicine in order to not develop what are usually bothersome withdrawal symptoms from something that people are physically dependent to. So you asked the question, how do I know whether I'm physically dependent? And that is a good question. What happens for most people is that if they try to stop drinking and they have difficulty, actual physical symptoms when they try to stop drinking, that's a good sign that you may have some physical dependence. But what I've found in talking to lots of patients over many years doing this work is that it is sometimes difficult to figure out what is the physiologic dependence and what is the psychological dependence. What is your brain saying, Jeff, you just don't feel very good right now. You would really feel better if you had a drink.
I've heard that voice.
Yes. Do you know who says that? It's this guy. It's that little voice in your brain.
I thought I had that removed as a child.
Yeah, that says, Jeff, you know you would feel better if you had another drink. So the big question is, am I physically dependent? What will happen if I try to stop drinking? Most people most drinkers, okay, have a pretty good sense of whether or not they are really truly physically dependent. I one of the first questions that I ask my folks that we're talking to about alcohol is, have you ever tried to stop drinking? And most of the time the answer is yes. And then I say, well, can you stop drinking? And they'll say, oh yeah, I can go for a week. I went for a week one time and I could stop drinking, but I just picked it back up again. And so that can help figure out if you have the real physical dependence. But, thinking about alcohol withdrawal syndromes, which is kind of the encompassing word for people trying to stop drinking. I came across some numbers, some stats recently that I thought were really, really a helpful way to think about this. So from some epidemiology, which is just the study of, how diseases affect populations, what we know is that up to half of folks who have alcohol use disorder may experience significant withdrawal symptoms. Okay, so half of, and I'm not talking about people, I'm talking about alcohol use disorder patients. So not the general population, but we're talking about drinkers.
Right, gotcha.
Okay, so up to half of people may have clinically significant withdrawal symptoms. But from a mathematical perspective, if you think about that, that means half of people won't have clinically significant withdrawal symptoms. So that was interesting to me. And then another piece in terms of numbers wise is that of the people who do have these symptoms, about 90% of them, 9 out of 10, almost everybody, those symptoms, which is not saying they're not there, but they're going to be in the mild to moderate range. Mild to moderate means not going to die. Mm-hmm. Okay. So, may experience some symptoms, may be uncomfortable, but may not be something that from a medical perspective, we are worried about people dying or, having really clinically significant outcomes. So I never want to tell people, oh, you're fine, you can just stop drinking on your own. But what I do want to reassure people is that most people who try to stop drinking, even if they get just a little bit of assistance with it, are gonna be fine. Okay? So here is the other really, really important piece. Alcohol withdrawal syndrome, mortality. So we're talking about death. Mm-hmm. Is reduced to less than 1% if you get any kind of treatment for it. So I'm sure you've heard from people, and I talk to people all the time. Well, I can't stop drinking because I'm afraid I'm afraid I'm dependent and I'm going to die if I stop. So I want to be very clear. If you are drinking so much that you know that you are dependent, and most people have a good idea that they are, a lot of people worry that they are, but most people have a good idea if they are, you can stop drinking as long as you get some help with it.
Well,
Now,
doctor,
yes.
if I mean, as a simple test, if I can go a day without drinking, am I safe? Is it 3 days? Because I don't, I'll never hit the lottery, but you give me a 1% chance of dying from, and I'll nail that every time. So it's still a scary, but you know, there's a chance I'm going to get hit by a bus today, you know, driving around, or at work tomorrow, you know, those
Right.
things. But I still take the precautions. But how for someone that's not sure, I can, you know, my wife will say, because she drinks hardly, you know, she doesn't drink that often. She knows she's not dependent in that sense.
Mm-hmm.
But there are people that are drinking every day. So if they can,
Mm-hmm.
you know what, yeah, this weekend we were out of town, I didn't drink at all. Oh,
Mm-hmm.
does that go ahead that, well, then you're probably good? Is there a way to help determine that?
Well, so again, you always, if you are concerned about this, probably need to be talking to a physician. The thing is that people can have medically supervised withdrawal, go through detox with as long as they are having open communication with their physician. This is something folks can do at home. You know, I think the model has been for a long time, oh, you know, I've got to check myself into some place, you know, so that
Right.
I can have this level of supervision. And certainly there are plenty of places that you can check yourself into, many of which are making, you know, money offering that
Right.
service. But for most folks, what we know based on this epidemiology is that most folks who are having this problem and may be dependent can have medically supervised withdrawal happen with some pretty simple medicines in the home setting that can safely get you through that time. So it's the American Society of Addiction Medicine is recommending outpatient detox, is what we call it, or medically supervised withdrawal for most patients that meet the kind of criteria that, yes, you know, I'm worried about quitting drinking. I'm acknowledging that I'm wanting to do that. I've talked to a physician that can prescribe some of the pretty basic medicines that need to get me through that time, and I can give it a try.
What are your other criteria for determining if someone is a good candidate for the home? My problem is you give me a bunch of Valium, and I think that's what I took in rehab, but you give me a bunch of Valium and say, Jeff, take one of these every 3 hours. And I'd call you at 11 tonight and say, how do I get a refill? Because
right.
You know,
yes.
So how do you know who's a good candidate or someone that, like me, that's, no, you're not good on your own. We know that.
Right. So what are some of those criteria? And I don't want, you know, this is an important conversation for every person to have with their physician.
Right.
So let's be clear, I'm nobody's physician here. I mean, unless you're currently my patient, and then we can talk. But I'm nobody's physician.
Come on in, everyone. Here. Come on in. Let's line up here.
I'm not giving medical advice, but what I'm wanting to do is help people understand that there are options out there for them. So in my practice, which may be different than other folks' practices, but what are some of the things that I'm looking for to help identify a patient like yourself or not yourself who might be a candidate for home detox? So let me just be upfront. I have done detox for people at home off of both alcohol and opiates. Has it worked out every single time? Nope. Do we understand the instructions ahead of time? I do my very best to, make sure. And when I say workout, I don't mean, I've lost patience or anything like that. But, sometimes it's successful, sometimes it's not. The things that I look for in patients is an understanding of how to use the medicines, when to use the medicines, and are they someone who can be responsible for their own medicine? So in your case, Jeff, what I might say about you, knowing you as I do, is, so, we both know that you may have a problem holding on to that kind of medicine. Where is your lovely wife that weekend?
Yeah.
And you might say, well, I wasn't going to tell her. And I'm like, well, Jeff, does that seem like a good idea?
Yeah.
And so, oftentimes, just some of the basics, I look for people that have someplace where they can be safely. So, for example, I don't usually detox someone who's homeless. I look for someone that has a support person there. Now, the support person doesn't necessarily have to be a spouse or a parent. Oftentimes it is. It could be a friend that's willing to say, yeah, I'll hang out with you for, 3-4 days. I look for contact with that support person. Okay. Usually if I'm working with a patient, I will say, can you bring your person in and let us talk, and let's make sure they also understand how the medications work.
So
and
when I tell you that I'll give Elizabeth that bottle of Valium for you, you don't buy that?
Right. Correct.
Yeah, smart move. Smart move.
Correct. Yes. And, the reason medicine is a practice, the art of medicine, is that, I don't always know folks, even as well as I know you, just having interacted with you for a couple of interviews, when they're coming in and saying, hey, I need help today. And, I have to balance, how can I safely take care of these folks? So, typically, especially if I'm working with someone that I've just met, I'm not going to give you enough medication that you can, right, go nuts on either.
No, it is the medicine that you will be, and I'm sure it varies, but when I went through rehab, I don't know if it was anything more than, well, I'm sure there was, but relaxation. I know there was Valium or something in there just to make me calmer. Is there other medicines involved? What's the purpose, or what do the other medicines, or what does your home detox consist of? Is it just to calm the nerves while you're going through this, or is there other stuff that helps it? What's involved?
So, right. So I'm not going to talk very specifically about specific medications, just because for every physician that kind of prescribing is going to be different, and people are going to have different comfort levels. Mm-hmm. If we talk about classes of medications, some of the medications that you have mentioned belong to the class of medications, benzodiazepines. Benzodiazepines are medicines like Valium, Librium, Klonopin, those kinds of things. And they are medications, pharmacologically, the reason those medications work well for alcohol withdrawal is that they ping some of the same receptors in the brain that the alcohol hits. So they actually can take away some of those withdrawal. It's not just about sedating a person.
Okay, that was my question.
Yeah, right. And I mean, that's the feeling, that's the effect that most people know from those medications. So they sort of think that's what it is. It's not just about sedating a person, though. It's about actually coming to some of the receptors that are the same as where alcohol hits to mitigate some of the withdrawal pieces. Typically, when we're using those kinds of medications, we use medicines in that class that are longer acting, because what they do is they kind of stretch out that sort of coming down off of the drinking. Those have been sort of the gold standard for getting people off of the alcohol, and they are controlled substances. They're something that most primary care physicians, they're not specialty sorts of medicines. They're something that most physicians can prescribe. Okay. There are lots of different protocols and things that people use to help folks detox. Oftentimes, if you are in an inpatient facility where they have the ability to medically monitor you and, respond if you were to become too sedated, a lot of times the cocktail that's given to folks is one that helps really just kind of sedate them and to a certain extent sort of sleep through some of the more difficult feelings that they may experience with withdrawal. From an outpatient detox safety perspective, I tell all of my patients, I'm not going to send you home with a bunch of medicine that's just going to have you absolutely gorked out, because that's not what we're looking for.
Damn it.
Yeah, right. But there are some other medicines that we can add. So what in my practice, I typically do kind of a short course of some of the benzodiazepines, the similarly reactive medicines, for like 2 or 3 days, and then transition over to something that may not be as sedating, but can help stabilize some of those longer term withdrawal symptoms. And so I will say, when I have had patients who are ready, what does that mean? We'll get back to that. Ready,
mm-hmm.
Who follow the directions, who check in. The feedback that I have gotten was, wow, that was just a whole lot easier than I thought it was going to be, and I'm feeling fine.
It sounds like you hear about recovery success rates, and that, and I know, like relapse and those kind of things, it almost sounds like the success rate of what you're doing is got to be in the upper 90s. The issues with the success are when your program ends in a week or whatever it is, and now it's up to me to start doing my work on my end,
right.
Where I'm the one that has to, now I've got to keep myself from drinking. And so that it seems like any negatives as far as success rates come on, it's not the program or the detox itself, it's me afterwards.
Correct. So there is, in addiction medicine, we have the saying, detox is not treatment. Detox is not treatment. Detox is not, I want this banner. Detox is not treatment. Detox is getting you ready to work your program. So that's what I was talking about. There are these two pieces to alcohol use disorder in terms of, in terms of phases of treatment. There is the making sure the person is safely off the medicine, but then there's the maintenance phase. Mm-hmm. And you are absolutely correct. The maintenance phase, I talk all the time about addiction being a bio, psycho, social, spiritual disease. Bio, psycho, social, spiritual. What can I help with? The biology, the physiology, the physical body-brain interaction of, can I physically get off of this substance, and is there a way that with the physiology, with medication, that I can control a little bit of that voice in my head saying, I need a drink. Can I have a drink now?
Mm-hmm.
And so what the maintenance medications can do is they can help curb some of those cravings a little bit to support you while you do the other work. Okay? So I have spouses.
Why do you keep looking at me when you say doing the work? It's like, I want you to look at someone else. I want to hear this sound. This is the sound I want to hear, not hey, Jeff, you need to. So I know you're talking the naltrexones. Yeah, exactly. I took Antabuse just as insurance. I have no idea it works, but the fact that they said you'll make you sick as a dog was good insurance for me. Mm-hmm. I did the injectable naltrexone. They called it something else, which is like a 30-day deal. Mm-hmm. And so what are those, and do they work?
Right. So there are a number of medications that can help, and I always use the phrase support your recovery. They support your recovery. They help support your recovery so that you can go to your meetings, so that you can meet with your therapist, mm-hmm. so that you can identify the other activities that are important for you. Like, for example, making music, So what are these medications? There are 3 that are FDA approved for kind of, if you consider the 2 different forms of naltrexone. The medication that most folks have heard about is one called Antabuse. The generic name of that is disulfiram. And that is a medication. It's not one of my favorite things to prescribe, but it's a medication that will make a person feel ill if they drink. Okay. I want to just clarify, because one of my patients came to me and said, well, I don't want you to give me the medication that's going to make me die if I drink. And I was like, look, I am not going to give you a medication
that you die, right?
That makes you die for something that you're, struggling to put down. Anyway, what the Antabuse does is that if someone does start drinking, it makes their body cannot process the alcohol in the same way. And so it gives them a very uncomfortable reaction to drinking. For most, but not all, for most of my patients that take this, like you, they were afraid enough mm-hmm. of feeling bad that it prevented them from picking up the drink in the first place.
Now, let me ask you a question about that, because I still have it around here somewhere, and it's my insurance in a bottle. And my thought is that if I'm going to go out tonight to a wedding, or some event that I know it's going to be a tough one, it seems like a great idea for me to pop one of those the day of, and that's it, just a one-time basis, or for the weekend, to get me through, just to give me that. I don't want to be throwing up in front of my friends after or breaking out in the splotches that you hear all the horror stories that
right.
you probably laugh about on your end. But is there anything wrong with that as an as needed? I did that when I was at a year sobriety and the Super Bowl weekend. I knew I was going to be fine, but I was scared that I was wrong. And I didn't want to take a chance at that point.
I advise my patients that medicine can be used after you have obtained a significant period of sobriety as needed. Okay. So I don't ever recommend that people start off with I'm going to pick and choose here and there. I'm going to take it. Generally, what I tell people for any of the daily medications is, and every patient is different, and this is not set in stone. And my practice tends to be very individualized. But generally, when I am starting a medication like that with my patients, I will say, let's plan to be on this for 6 to 12 months to really get your recovery well established. And then after that point, we'll see where we are. And that medication, as well as the naltrexone, can be used, as you are talking about, kind of as an insurance policy. The thing to keep in mind about that medication is that you want to make sure you are a week or two off the medication before you have anything to drink.
Yeah.
But you and I have spoken, and I hope it's okay for me to say this.
Yeah, please.
I think that you are pretty clear, for example, that drinking is never really going to be a good idea for you.
Mm-hmm. No,
so,
but you know what? The point that I love about support, years ago, I quit for quite a while just on my own. And one of the things I got was naltrexone.
Yeah.
Because it takes away your craving.
Yes.
I wanted a pill to make me not want to drink. I wanted it to do all the work. And I wasn't working anything other. The only thing my only sobriety was based on that pill making me not want to drink. And I still wanted to drink, and I fought through it. And I didn't like it. It made it hard to drink. The beers didn't taste right. They kind of had a metallic taste. I had to drink a lot more, but damn it, I'm not a quitter. And I fought through it and drank. And then I realized, okay, well, it's not working. So I stopped taking it. And then everything just even snowballed even more. So yeah, I love what you're saying, that it is great in support of an existing program. I had nothing other than, hey, this magic pill is going to take care of, I won't have a desire to drink anymore.
Right. So let's talk a little bit about naltrexone. So naltrexone is in my practice what I generally go to first line, but it does depend patient to patient and what their experiences are. The beauty with naltrexone is that, as you point out, it doesn't make you sick when you drink, but it really does seem for most people to curb the cravings some, and also for most people, if they do drink when they are taking it, they seem to be able to drink less. There are a group of people that use naltrexone, and it's fine that they do that, but they use naltrexone more to control their drinking than to stop drinking. And it seems to be very helpful in that situation too. Now, controlled drinking versus stop drinking, that's another ball of wax that we can get into. And for many patients, if they have reached a certain threshold, controlled drinking is not a good option. There are some patients that's their goal and that's where they want to get to, and it works well for. But anyway, naltrexone, because it seems to cut those cravings some, and also to, if somebody does start drinking, to be able to set it down. The very first patient I had on that, it was so interesting. He came back and I'm always kind of saying, so how was the drinking? And he was like, well, it was kind of weird. And I said, well, what was weird? And he said, well, I only had 4 drinks. Now understand that this man, he was dedicated. If he was going to drink, he was going to have 12.
Oh yeah, that was me.
Yeah. Right. So he came in and he's like, it was just
start
weird.
The evening off.
I only had 4. And I was like, and then what happened? And he's like, I don't know. I just went to bed. So, again, not that that's the way I necessarily recommend establishing yourself in recovery. But I mean, the other point that's important, as you've mentioned and alluded to a couple times, people get to different spots in their recovery. And if control is where you get to, and that's a step along your way, that's good. So naltrexone is a good medication to support that. Generally, I will, if people are able to access it, recommend the monthly injection that you've mentioned. The product name of that is Vivitrol.
That's it.
Yep. So Vivitrol is a 28-day injection of the naltrexone that just stays in your system. What I see for most of my patients is that the delivery of the amount that you kind of have in your bloodstream is a little higher and more consistent. It doesn't rely on you taking a pill every single day that you can forget or accidentally on purpose forget. Mm-hmm. And for a lot of people, it just works better. Now, I will say naltrexone does have a genetic component to it, like many of our medicines. And there are some people that it works really well for. And I've had a handful of patients that it has seemed to have like virtually no effect on their drinking. Now, I could run that several $100 genetic test, but usually what I do is I just try this medicine and then kind of see where we are. I mean, one of my patients, she was just extraordinarily dedicated to her drinking, and we did probably a couple months of the injection, and I said, how do you feel like this is working? And she said, I don't think it really is. And I said, I don't either. So, that's when it might be time to try something else.
The want, because looking back, I took with the naltrexone almost as a challenge to this stuff curbs your drinking. I'll show you.
Right.
That's how messed up my mind is, how I work in my head. But it was like, I'm going to prove, I wanted to test it to see if it really worked. So I'm going to drink to prove that that it's not some magic pill. Mm-hmm. And it was my goal. So now we go back to, did I even want to quit, or was I hoping that some magic pill would take? I didn't want to quit. And
right.
So how do you determine if you got a person like me that's saying, yeah, everyone's bitching at me and I got to go see you because I got to stop drinking, versus someone that's there for the right reason going, you know what? I am willing to do whatever it takes. I have to stop. I have to, and I want to. How do you determine that?
That's a great question. I love that question, because here's the thing, Jeff. It doesn't really matter. My door is open to everyone. And I recognize that even if someone doesn't have a successful attempt, walking through the door and trying has given them one more step closer to understanding where they need to be. And, I don't, everyone, when they call me, tells me they want to quit drinking, right? Mm-hmm. Because that's the right answer. And do I believe all of them? It really just doesn't even matter. Because if someone is willing to try to stop drinking, helping them with that attempt will help them, when 2 years from now, they're like, oh, no, wait, I really, 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 really have to stop drinking. Mm-hmm. I mean, one of my favorite patient stories, I I met with a man who he's been drinking for years. I mean, he's just, that we would use the phrase functional alcoholic, drinking for years, ups and downs with, how that has affected his life, and came in to see me. We talked about all the options. We talked through some of the medication options, and I gave him a prescription for the naltrexone. And he said, I don't know if I really need that. I want to go back to AA, because he had also, he had been in and out with AA, which we're not promoting one program over the other, but is a good program for a lot of people. He said, I think I want to, just go back and get plugged in with AA. And I said, fine. I said, take this prescription, get it filled, have it in your house. And if you get to a point later that you feel like it's time to add the supportive medication, you can start taking it, and just give me a call. Mm-hmm. And 6 months later, he did. And so, I mean, I
guess that's not your responsibility to make that call. The responsibility is me.
Yep.
It's my responsibility to make that call. Yep. One of the things I hear a lot, and I know I said it with naltrexone and some of those in past attempts, it didn't work. Mm-hmm. Well, that Peloton that I have sitting over on the other side of the basement, I've had it here for 2 weeks, and I haven't lost any weight or gotten any. It's not doing crap. It's not
working, is it?
It's not working, and I'm waiting for it to work.
Yeah.
And it's the same thing with the medicine. Doesn't work unless you work it. A program, I come from AA, and people that say, oh, AA doesn't work. It does. No program works. It's a tool. This hammer doesn't build a house, but it's a tool that I can use to help me more effectively and easier build a house. Mm-hmm. It won't do it by itself. It's just like that Peloton that sits here. The program of AA doesn't do anything for me, or the program of Smart Recovery. I have to work the programs. And I guess the same thing, I take this magic pill that I'm hoping you give me, and okay, it's not working. No, it's a tool to go with. It has to come from me first and complement without if I don't add myself to it, I guess nothing's going to work.
Right. And I'm so glad you brought that up, because I have patients that come to me and they're like, oh, I've tried naltrexone before, and I say, okay, well, tell me about that, and if they say, well, I started taking it and I developed this severe purple rash and, all that kind of stuff, I say, okay, no naltrexone.
Right.
But if the response is, well, I took it and it didn't seem to help, I always like to explore that a little bit further and say, well, maybe people's bodies change, people's responses change, just kind of with the idea that maybe it wasn't the naltrexone that wasn't working. I have I am very involved with my patients. I spend a lot of time with them, and the therapeutic relationship that I develop with my patients, I believe, is one of the important components of their recovery. That said, I explain to all of them, I want you to do well, but I have nothing invested in your recovery. Like, if you fail, I'm going to be happy if you succeed. If you fail, I am not going to be disappointed. Like, I don't my disappointment, my acceptance is not part of this package. And I try to be very clear with my patients. You probably know some of the psychology around the lying and the hiding and the, folks are so used to some of those behaviors around their drinking that I don't ever want them to feel like they can't come to me and say, look, this is not working. I'm still drinking. Because if they're still drinking, we need to problem solve that together, So it's why I try to be very careful, when I'm talking to my folks, I don't say, so have you had anything to drink? I say, so how's the drinking going? What are
Mm-hmm.
so that we can work on that together, because like you were saying, it's not my responsibility to get them to meetings. Doing the kind of work that I do, I have to be clear about boundaries and responsibilities and but I'm still here. I'm still here to support people, even if, and they leave here sometimes and I'm shaking my head and thinking to myself, that's not going to work.
Yeah.
But, I have had a number of patients who have left the practice and come back, and they've gotten to a different spot.
Mm-hmm.
And,
well, I did.
Yeah.
Right. I was a perfect example of it. And I think with you being a physician, you're probably, I thought that I thought I lied to myself more than anyone else. I know, than even my wife, my kids, my friends, but I'll lie to you. I'll lie to you even more than I lie to myself. How many of you had? It's embarrassing. I don't want to, I don't want to tell you, I was a massive beer drinker. I drank over 24 beers a day, every day, more on weekends, easily. That's embarrassing to tell. It's to see that shock. I'd rather tell you, yeah, I had 4 yesterday.
Right.
Because I know I'm supposed to, as a man, as a male, only have 2. I have 4, so I'm drinking too much. I'm not going to tell you the truth because it's embarrassing.
Right.
Or I drank Saturday night, the big weekend. We had it was the 4th of July weekend last weekend. Had a huge, that was a couple bad days. What about Monday night, Tuesday night, Wednesday night? Well, the truth is, I drank just as much as I did on the days that I was supposed to drink, or I feel less guilty about drinking on those days. I don't want to tell you those things.
So, I am taught in the clinical setting about it's very important to get an accurate history of your patient's substance use and, what they've been using and how long they've been using it. And to a certain extent, does that help me get a feel for, like, are they really going to have withdrawal symptoms and things like that? Yes, it does. But I would say that I would focus less. I generally focus less on trying to get an accurate picture of, like, okay, Jeff, really, actually, how many beers did you drink in the last 24 hours? I mean, the beauty of my practice is that it's an addiction medicine practice. And if you walk through that door, you're saying to me, I've got a problem. And if you're saying, I've got a problem, I've got a hammer. Mm-hmm. I've got some things that I can help you with. I have a couple of patients right now that are using some of these medications, and I say, how's the drinking going? And they're like, oh, it's okay. And so then I ask a couple of questions. I say, are you driving? And because we're very clear about that. Mm-hmm. That's not okay for you to be driving.
Right.
Are you driving? Are you hurting yourself in any way when you're doing this? Are you hurting your relationships in any way? and we kind of discuss those things, but I don't try to, say, okay, tell me exactly how many ounces you're having, and what are you drinking? And we just try to continue to work on that. Part of addiction medicine work is in the realm of harm reduction. And I think you've talked a little bit about harm reduction some on your show. What we know in the field of addiction medicine is that a dead person is not going to recover. And sometimes what we're looking for is not to get somebody, sober and a productive member of society and changing their life. We're trying to keep them safe long enough that they can get to that other point in their life where, like you realize, you know what, I thought it wasn't working before, but now it's really, 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 really not working. And I maybe actually really have to do something about this. And so, some of what I do, do I think some of my patients should probably stop drinking forever? Maybe, but if that's not where they are, I'm not, it doesn't, it doesn't do them or me any good to lecture them or try to get them to another place. What I do is I continue to, provide some tools that may help them drink less and, continue to see them regularly and continue to kind of, do some safety contracts with them and like, hey, can you really make sure you're not driving? And, we don't want that to become a problem. And so, we, and I will sometimes in the chart say, for harm reduction purposes, we're going to continue assuming this person is going to drink and just make sure they're being as safe as they can.
Can you, there are people, the goal can't, I just want to be able to go out. Is there anything I can take? I just want to be able to go out and have 2 beers or 2 glasses of wine with is there anything that's going to make it so that I don't crave any more than that? And I don't think that's reasonable or attainable, but that's everyone's goal. My wife can have a beer or 2 and just be fine. I am miserable if I have a beer or 2 and even think about stopping. Once is there anything for someone that just says, I just want something that's going to take it away enough where I can just have 1 or 2 and after work or out and then be able to go home?
So, so the very short answer to that is, from a medication perspective, that is when a medication like naltrexone, if it's going to work for someone, probably that would be the recommendation. Now, what I tell folks is that you can't go from 24 beers a day to 2 every 4 days in one swap. And what I tell most people is that you have to kind of reset your drinking and your behavior and your physiologic dependence in order to get to a point where you may be able to experience controlled drinking. So I know this is a very non-AA perspective, kind of once you've identified a drinking problem, you can never drink again for the rest of your life. There are some people, I believe, that can learn to drink responsibly, but you don't go from 24 to 2 the next day. And what I recommend to all of my patients who find themselves caught in that cycle is that you probably need to give yourself a period of abstinence that allows your brain response to reset to the substance. It allows your dependence level to go down. And then you may be able to get back to a point where you can have more controlled drinking. Sometimes the drinking becomes a habit. I'm working with a patient right now that, I come home and I drink every night, not driving. Work is not suffering. Family life is not suffering, he says. And it's part of my habit. And I come home and it's just what I do. And he's saying, I don't, and I have ways, and we've talked about this before, I have ways to assess, do you meet clinical criteria for alcohol use disorder? And this person may not meet criteria for alcohol use disorder, but is drinking too much. And he knows it. Medically, it's not a good long-term plan. And so what I tell people is that it's possible that you may be able to get to a point where you can have controlled drinking, but you gotta probably allow yourself some space to let that reset.
That is not the case for me in my, I'm going to say I know that. I went, doctor, 9 years of abstinence years ago. I just stopped. I used a program called Rational Recovery. I was in but I don't know how much I was white knuckling it. I know I was getting none of the benefits that I get now from sobriety. So I was doing something wrong in it. I wasn't doing it right. But 9 years, I remember the first night that we agreed I didn't have a problem, which was a great call on my wife regrets that night, feeling that way. I had 1 beer. The next night I had 3. And I believe the third night I was a 12-pack on up. And I was right back. And that was after 9 years of having nothing. And it came back almost immediately. And my desire, nothing went away. My point is, for me, nothing went away in 9 years. And I know, at least I believe, for me, there's no way. And there's no enjoyment of having 1 beer or 2 beers. Maybe I could do that and white knuckle it, but it's not, I'm not happy.
Right.
I'm miserable.
Yeah.
I'm not drinking like I want to drink. That's for damn sure. So I don't know.
And that is, we are genetically predisposed to how we respond to alcohol. We are genetically predisposed to whether or not we will suffer from addiction. There are folks that have drunk enough in their life that anytime they drink, they go through clinically significant bad withdrawal. I'm talking about like seizures and things like that. I mean, I have a patient in his 20s that has had enough to drink and maybe had, the predisposition for it. He can't drink because if he drinks, when he stops, he will seize. And it's just, I mean, he just, it's not an option anymore. And he knows that. So, I think everybody needs to sort of assess where are they. I mean, the other thing, and we haven't even touched on this. I'm going to have to come back, I guess.
Yeah, I know we're at the top of the hour. I've taken you way too long, but
no. But I mean, the effect of the pandemic and why are you drinking? And you and I both know that alcohol sales did not suffer this past year. And why are people drinking? And kind of exploring some of that. And this is another topic that we haven't even touched on. But you've mentioned someone with depression and alcoholism, which is an extraordinarily common co-occurring disorder. I've had a handful of patients that we have simply started treating their depression. And guess what? their alcohol problem went away.
Mm-hmm.
You know, and so
well,
I mean, there's
alcohol for me is what I did to cope with my problems.
Mm-hmm.
I mean, that was when alcohol really took off for me was when I got hit with panic attacks,
Mm-hmm.
and that was the day that
Mm-hmm.
it entered the medicinal world, and then it became medicinal for panic attacks and anxiety, and then it took over for all sorts of things and became I lost it was my answer to everything. So there's a whole, but we're at the top of the hour. You know, I have it at the bottom, the mel-med.com is got so much information. I'm going to put a link to that if you're okay on our webpage. But there is so many resources there to go with. I think on the page, if anyone does want to get a hold of you, there's contact info. We will definitely have you back. Yeah, I have the 40 questions are now up to 372. You know, and I could just do this all night. You've got so much, but thank you so much. Is there anything else or advice or last closing you have for anyone that's ready to make this decision or decide if they're ready?
I mean, I guess if you're sort of thinking about, hey, do I have a problem? My friends at AA say that the answer is usually yes. And, I would say just know that there are options out there, that there are lots of different ways to find recovery. There's no set program. And, I think the hardest thing for most people to do is to say, hey, I need some help. I have found I've had a couple of patients recently that have come in and said, just said, hey, I need some help. And by the time they left their first visit, they were feeling better. We had some really kind of simple plans in place, and they're actually doing really well. And so, this isn't my work. This is your work. And just letting someone, offer you a bit of guidance and support,
I guess if it's something you're thinking about, that spot on my arm, I'd rather have I'd rather take a look at it and treat it and find out it's just a freckle than ignore it and find out down the road that by ignoring it, it blossomed into something that now is a much bigger problem. I don't know. It's tough. Well, look, thank you so much. Hang on just a second. So we'll be back. The website is up and being developed, gettingbacktozero.com. We'll have these resources. This video will be available to be viewed on that as well at any time. And we'll have all the contact information. So we definitely will have you back on. Great stuff. Thanks so much.
Excellent.
Take care, everyone.
Bye-bye.